So what are the unmet needs? We obviously have an unmet needs in the diagnosis and the prognosis, and we really are short of good markers. What we know is that we don't really have a good comprehensive genomic understanding of non-muscle invasive bladder cancer. We perfectly know that there's a very highly variable behavior, which is not always captured simply by the pathology low grade and high grade. So the major pitfalls is that we have no urinary diagnostic test. We have nothing non-invasive that would easily replace invasive cystoscopy and cytology. And we don't really have a very good prognostic test for tumors which look exactly the same under a microscope. And so if we think about a new diagnostic test, something that would be an early diagnostic test, today we rely on cystoscopy. We know it's invasive, it's investigator dependent, it is costly. Cytology, thus the analysis of the urine cells under the microscope, it does detect aggressive tumors, but misses quite a lot of them and is short of good sensitivity and specificity. So we are in dire need for a new test. In the past, many tests have been investigated, and this busy slide shows you that none of them is up to replace the cystoscopy and the cytology. Their performance is just too poor. We now have taken advantage of our bare understanding of the molecular biology of bladder cancer, and the one that I told you is the epigenetic changes, so the modification of the DNA with the same type of mutations. And the advantage is because this DNA is very stable, and therefore it's easily detected and stable in the urine as a urine test. Several groups have found that when you looked at these epigenetic changes in the urine in patients with bladder cancer, you can actually pick them up very accurately and with sensitivities and specificities which are not far from being perfect, much better than the cytology. Now, several other groups in Canada have done the same in conjunction, and several of the genes which are mentioned on these slides have shown to be very effective at pinpointing those patients with bladder cancer as a non-invasive diagnostic test. However, most of those studies are still relatively preliminary and clearly deserve validation before they can become a standard of care. In terms of prognosis, what we're missing, as I said, is the ability to differentiate between the pussycats and the tigers. In the past, we have had some of the genes that I have alluded to, like FGFR3, that has been shown to be able to differentiate between bad and good players, but still, it's far from perfect. We have had advances where when the tumor was going to the second layer, which is the PT1 high-grade bladder cancer, differentiating those with a massive infiltration from a minimal infiltration was also predictive, but again, very far from being perfect. So we need something better, and what we are currently missing in bladder cancer is this. Again, a busy slide, but shows you that when a woman has breast cancer, there are lots of genomic tests which are commercialized based on a lot of genes which are abnormally expressed in breast cancer, and that will predict her chances to respond to a treatment and how aggressive the tumor is. The same from colon, the same for many other cancers. We don't have that in bladder. Maybe the future will be to have commercially tests like the one that was studied by Peter Black in Vancouver and other investigators in the States, looking at the expression of a variety of tests on bladder cancer and predicting outcome. This test is not commercially available, but who knows? The same, if you take the transcriptome that I explained previously, you dissect the tumor, you analyze the tumor, and you end up with a prediction of the ultimate aggressiveness of the bladder cancer.